So Mr. Perrone is the Director of Improving Access at the California Healthcare Foundation, which works to ensure all low-income Californians can get the care they need when they need it. Chris oversees the foundation's efforts to expand access to affordable coverage, to strengthen the Medi-Cal program, and to foster delivery system transformation and workforce solutions that expand the capacity of safety net organizations to provide timely, high-quality, and patient-centered care. Mr. Perrone, when you're ready.
Great. Good afternoon, Chair Wood, Chair Amberlin, members of the committee. And thanks for the invitation to talk with you today about Medi-Cal enrollees' access to care. Also, I wanted to thank the committee staff for all the work that they did in helping us prepare for this hearing. It's much appreciated. At the California Healthcare Foundation, we believe that all Californians should have access to comprehensive, affordable health care coverage. And we have been monitoring access to care in the Medi-Cal program for 2 decades, partnering with some of the top researchers here in California, as well as nationally, and also partnering with many different partners in the public and private sector to improve access to coverage and care for low-income Californians. We've also partnered in recent years with the Department of Health Care Services to survey Medi-Cal enrollees and to develop dashboards to better monitor access to care. For my presentation today, I'm going to briefly describe a framework for how we think about access to care for anybody really, but low-income populations. And then I'm going to share some findings from our research and research done by others. I'm going to focus on non-elderly adults since they are the focus of our efforts to expand coverage to the remaining uninsured. I'm going to focus on California research and then focus on the comparison between Medi-Cal and the uninsured and Medi-Cal and the individual market. Since, again, thinking about the choices that we have before us. I want to discuss briefly some key program features in the Medi-Cal program that I think are important in addressing access to care for any low-income population. And then I'll briefly summarize before presenting some opportunities for improvement. So as we think about different ways to measure access to care, we, working with researchers at Mathematica Policy Research, developed this framework. It looks at 3 areas: potential access. What are the characteristics of our coverage system and our healthcare delivery system? Are they promoting access to care? Realized access, what's the actual experience of people? And then finally, health outcomes. When we start at the top, some of those are the easiest measures to collect, the easiest data to collect, and often the most directly attributable to the policy choices that we make. As we work farther down this list, you get into a number of complexities in terms of attribution, both to the policy decisions and also the complexities of both measurement and the differences in different populations. But I'll try to present and discuss some data on all 3 elements. Before getting started, and this came up in the question and questions to Larry Levitt about Medicare populations and other populations, there are important differences in the populations across different coverage types. And these have very important implications for what we see in the access data. So when we compare Medi-Cal enrollees to those with private coverage, or we compare them to the uninsured, it's really important to understand that we're not comparing apples to apples, and we can dive a little deeper into that. One other thing to mention is that in my presentation, I'm not going to talk about children partly for the reason I mentioned before, where the remaining uninsured are predominantly adults. In fact, 98% of children here in California are covered, thanks in large part to a number of Medi-Cal expansions. But what I would say about children is that the research generally show that children in Medi-Cal, their experience with access is similar to children with employer-sponsored insurance, and tends to be much better than adult Medi-Cal enrollees. We have special protections for children, including the early and periodic screening, diagnosis, and treatment requirement. We have special higher payment rates for specialty care under the California Children's Services Program. So there's a number of contributing factors to the fact that children enjoy better access than adults in the Medi-Cal program. In the last few years, however, we have seen a surprising rise in the share of parents reporting difficulty finding specialists for their children. We are fortunate that DHCS has created a new dashboard to monitor children's access to health. And it shows a mixed picture: steadily increasing utilization of mental health services, but opportunities to improve access to and use of dental services, and some declines in quality of care over time. So an important population, but won't be the focus of the remainder of my presentation. At the California Healthcare Foundation, we have been fortunate to work with Drs. Andy Byman and Dr. Janet Kaufman to track over about 2 decades physician participation in the Medi-Cal program using and with the Medical Board of California using a supplemental survey that physicians are asked to complete when they renew their licenses. And it gives us a unique insight into physician participation in the program, something that, frankly, when we talk about this at national convenings, other states are really quite jealous of. What we find from this work is that about 64% of physicians in California participate in the Medi-Cal program, and 60% accept new patients. And as you can see, that's quite a bit lower than it is for other forms of insurance, and quite a bit above their participation in serving the uninsured. Dr. Kaufman and her team in the latest survey have also found that the ratio of physicians to enrollees is in 2015 is below not only national guidelines, but also the department's own standards for its managed care plans. So we don't have enough physicians to serve the Medi-Cal population according to the state's own standards. I do want to acknowledge that this physician self-reported data and self-reported data in general has its limitations. However, we have examined a number of other ways to track physician participation in the program, including from drug claims and medical claims, and found this to be a superior method. From this same survey, we asked physicians why they do not participate more in the Medi-Cal program, and we found that the number one reason, probably to no one's surprise, is payment. But they give a number of other reasons as well, and when we talk with physicians participating in the safety net, one of the things that we often hear as a concern of theirs, particularly among primary care physicians, is the difficulty they have referring patients to specialty care. And so specialty care is a particular challenge for Medi-Cal enrollees. One of the benefits we have in California is the California Health Interview Survey. It's a general population survey conducted annually, and it allows us some very robust comparisons between different populations, including Medi-Cal populations and those with other sources of coverage. And here are a few slides that compare access to care for Medi-Cal enrollees to other payers, and we see that access to care for adult Medi-Cal enrollees is generally comparable to adults in the individual market, and certainly much better than the uninsured. One noteworthy finding reflected in the chart in the upper left is that Medi-Cal enrollees are just as likely to have a usual source of care as those with coverage through the individual market, but where they get their care is different. As you can see, the majority of Medi-Cal enrollees say they get their care from a health center or clinic, whereas the majority of those in the individual market say they get their care in a doctor's office. And this is consistent with some data that we've have from the Medi-Cal managed care plans that say 40% of their members get their care from federally qualified health centers or lookalikes, and 50% of the newly enrolled Medi-Cal members under the Affordable Care Act. Using the California Health Survey interview data again, looking at taking a closer look at some of the access, we see that adult enrollees are less likely to forgo care due to cost, but have more difficulty getting timely care. So the survey asks people whether they forgo care and why they forgo care, and you can see that the reasons are quite different, and we're going to get into those in just a bit. Another look at this issue of timely access is from a study done in Sacramento by Dr. Joy Melnicow and her team at UC Davis. Using a secret shopper approach, they called the offices of physicians listed in Medi-Cal health plan provider directories as accepting new patients. The blue bars show the percent of physicians who had any available appointment to offer a new patient. In some counties, 1/2 of those contacted said they had an available appointment, while in other areas, as few as 1 in 4 physicians had an available appointment. Again, only physicians who said they were accepting new patients were contacted as part of the study. The orange bar shows what happens when those same physician offices were asked whether they had any appointment within 10 days with any provider in the practice. So the first question was just asking about a particular provider that was listed in the provider directory as accepting new patients. The second question is saying, any provider in your practice, can I get in within 10 days, which is state standard for primary care. In most cases, the value drops dramatically, indicating that physicians cannot meet this need in a timely manner. And in one county, Yuba, the percent actually rises. This reflects that in some cases, even though the original physician may not have an available appointment, another physician in the practice does. Emergency room use is certainly a hot topic in Medi-Cal, one that people pay close scrutiny to, in part because it can often be a signal of poor access and also because of its high cost. These figures shown on this page reflect the percent of people by coverage type that visited the ED at least once in the past year. And as you can see, Medi-Cal enrollees were significantly more likely to visit the ED than those with other sources of coverage, and also more likely than the uninsured, who often avoid any type of costly care. A closer look at the data, however, revealed that these differences are largely a reflection of differences in the populations. So when we look at just those in fair or poor health, we see the gap between Medi-Cal and these other payers shrink. And when we control for both health status and disability, we see the gap shrink even further. So oftentimes, the differences that we see in access are not so much a function of the program, but of the populations they serve and the variety of challenges they face in their lives. This set of charts, which looks at just the Medi-Cal population, touches on a similar issue. You can see that among the Medi-Cal population or within the Medi-Cal population, there are wide differences in their experiences getting access to care. This is by no means a comprehensive look at this issue, but it does highlight that, that the program is serving different enrollees in different ways, both in terms of their characteristics and also geographically. Since 90% of Medi-Cal enrollees are now served through managed care program, I thought it'd be interesting to spend a little time on and useful to spend a little time on the managed care program. This first slide comes from the Department of Health Care Services' own Medi-Cal Managed Care Performance Dashboard, and it shows the tremendous variation in performance across managed care plans in Medi-Cal. The names of the plans are probably too small to see, but I hope the major point isn't lost, that there is this tremendous variation. And that what we see here is that there are some plans that are providing excellent quality of care, and then if all Medi-Cal enrollees were in plans that provided that level of quality and access, there would be much greater access to primary and preventive care for all Medi-Cal enrollees. Again, looking at the Medi-Cal Managed Care Program, Member Waldron referred to the HEDIS data set, quality data that is established by the National Committee for Quality Assurance. And this looks at 6 of the measures that the department has decided to use in what's called its auto-assignment algorithm. This is a method by which the department takes enrollees who don't choose a health plan themselves and uses to assign those beneficiaries to a health plan. What it essentially means is that these are the 6 measures that DHCS with its stakeholders have said, these are really key measures for us in terms of measuring quality. So among the many measures that we could look at, this is why I'm looking at these 6 here today. And what you can see is that the quality of care in Medi-Cal managed care is similar to the national Medicaid average, but not improving. And there's a couple of ways to look at this issue. On the one hand, we would hope to see continuous improvement in the program over time in managed care. That is largely a charge of the program. On the other hand, given the rapid growth in the program in the last few years, it might be some small comfort. There hasn't been a serious decline in quality. There certainly have been calls and questions about whether or not Medicaid programs nationally can handle both the traditional Medicaid population and an expanded population, and this data would suggest that the quality of care has not deteriorated for Medi-Cal during this period by and large. I wanted to also mention that public plans play a very unique role in the Medi-Cal program. You can see they represent the three blue or bluish-like segments of this chart here. So they account for a majority of the members. But even more than that, when we compare the performance of the public plans to the commercial plans participating in Medi-Cal in those counties where there are both kinds of plans, generally the public plans perform better. And when we have looked to see what investments health plans are making in their communities to improve their delivery systems, generally what surfaces is large investments by public plans. This is not universally true. Some plans are taking a more active role than other, but generally speaking, it's fair to say that the public plans are taking a deeper and longer term investments in their communities. So I want to mention several features of Medi-Cal that are intended to promote better access, because I think this is important in considering any types of coverage options that you give to low-income Californians. The first is that Medicaid is a very expansive benefit, including dental coverage and transportation services. It has no or low premiums and cost sharing. There are numerous legal and administrative protections for Medi-Cal enrollees. I mentioned the EPSDT requirements before. There are higher payments for selected providers under the California Children's Services for federally qualified health centers, for example. And then there's unique enrollment options. So there's year-round enrollment in Medi-Cal, which is something that is not available on the individual market or through employer-sponsored insurance. I also wanted to mention that most Medi-Cal enrollees have a positive perception of the program. So despite many of the challenges, when you ask beneficiaries about their experience, in general, they say it's good. When you ask them about the perception of Medi-Cal, most say it's either a very good program or a pretty good program. Now, this was a survey that was done before the Affordable Care Act was enacted, before the expansion. We did this survey in partnership with the Department of Health Care Services. We would appreciate the opportunity to do it again and love to partner with them to do that. But so far have not had the opportunity to do so. But this is, it was a state-of-the-art survey that looked across. A lot of the survey data of Medi-Cal enrollees focuses only on the managed care population, and this looked at both the managed care and the fee-for-service population, which is important because the fee-for-service population includes a lot of seniors and people with disabilities who request and receive medical exemptions. So this is just a summary of the findings. In the interest of time, I won't repeat them here, but I will add that while Medi-Cal does face some big challenges, Medi-Cal enrollees are certainly much better off because of the program. And then I wanted to leave with some ideas for improving access. The first is that there is clearly an opportunity to improve health plan performance, and one simple idea that could have great impact is to pay them differently. For example, just as many Medi-Cal health plans pay their providers with a pay-for-performance bonus, we could do the same in the state, paying health plans more that are improving quality and access and performing better, and paying those less that don't. A second is to encourage plans to expand access to telehealth. The public healthcare systems in San Francisco and Los Angeles have used electronic consultations and referral systems with great impact, reducing unnecessary services and visits to specialists that could be avoided, and cutting off months off of waiting times for those that needed specialty care. Similarly, live video and stored forward telehealth are connecting both rural and urban providers with specialists and improving access to those areas. Arguably, any plan that's serving a rural population or receiving an exemption from the network adequacy or timely access standards should have a robust telehealth program to better meet the needs of their enrollees. Third, through its waiver, the Medi-Cal program has been investing billions in the transformation of care delivery systems through the public UC and district hospitals and in the state's substance use delivery system. Such efforts to build the capacity we need now are important now and in the future, and should be expanded upon to include federally qualified health centers. Fourth, we need to invest in building a workforce for the future, one that emphasizes patient-centered, team-based care. Assemblyman Wood and Senator Hernandez are serving on the California Future Health Workforce Commission, and I hope that the recommendations of that commission will be discussed and acted upon. And then fifth and finally, for all that we do to track network adequacy, timely access, and health outcomes, we could and should do better. I truly applaud the efforts by the Department of Managed Healthcare Director, Shelley Rouillard, and her team to advance better measurement of access and bring greater transparency. This work should continue and be expanded upon. Thanks for this opportunity.